dressed in the morning, and I took her to a neurologist, and he did a little exam, and he diagnosed PCA, and she actually died this year, like a month ago, and I've stayed friends with her for that long. And I just think it's very important that we really educate people about this, because I think it hits in the prime of midlife. I think it takes people by storm, and there's just a lot to be had. Anyway, Michael's back. I'm going to introduce Victoria Pelak. I met Dr. Pelak on a story I did. I write for Neurology Today now, and I did a story on new PCA guidelines earlier this spring, and you will really get a lot out of this. She is a professor of neurology and ophthalmology, as her slide says, at the University of Colorado School of Medicine. Dr. Pelak, take it away.
Okay, I want to thank Jamie and Michael very much for allowing this, what is sure to be an incredible resource for people who find it difficult to understand PCA or be able to find somebody who can understand PCA and give them the resources they need. So thank you very much. So I'm going to be talking about visual perspectives, and just by way of introduction, as Jamie said, I'm a professor of neurology and ophthalmology, and my subspecialties are neuro-ophthalmology and behavioral neurology, and I work with the Rocky Mountain Alzheimer's Disease Center and the Lions Eye Institute here at University of Colorado. And for those of you who missed the first webinar that was given by Dr. Rabinovich, I highly recommend going to Jamie's site and reviewing that. It is an excellent overview of posterior cortical atrophy, but I wanted to just touch on the main points for those who may have missed it and would be interested in some of that information. I'm also going to discuss the stages of PCA. That was something that Jamie felt would be very important to cover. And then I'm going to spend the majority of the time really discussing how PCA affects the visual system. And so we're going to have some anatomy in there, but I promise to try to present that in a way that really corresponds or helps you understand how it relates to symptoms of PCA. So first off, what is posterior cortical atrophy? Well, a very simple way to describe it is that it's a progressive loss of function as well as brain cells in the posterior regions of the brain. And why your vision is affected with PCA is because these posterior regions have significant amount of areas dedicated to visual function. There's other functions in the posterior regions besides visions, and we'll talk a little bit about that, but most of the symptoms of PCA are related to vision because that area of the brain or that region is dedicated to visual function. As Jamie said, the onset is very early compared to other disorders within this category that we'll talk about. And the onset is in the 50s and 60s. And because of that, as well as because of the type of symptoms people have, it can be very disabling and sort of affects people in that prime area of their life when sort of many things start to come together for people. So I'll get this right in terms of my slide movement. So what diseases can cause PCA? That's really the number one question many people ask, is how does this differ from Alzheimer's disease, and what else can cause it? Well, I put here the main issues or the main diseases that cause PCA, Alzheimer's being by far the majority. Likely up to 80% of people have Alzheimer's disease within the brain causing the PCA symptoms and syndrome. And it can also be combined with another disease called Lewy body dementia, which is most likely the second most likely cause for dementia. And now, through several associations and consensus, Parkinson's disease dementia and Lewy body dementia are really becoming known as one disorder. They present a little bit differently if you present with Parkinson's first versus presenting with cognitive impairment. But a small majority of people with PCA will have both Alzheimer's and Lewy body disease, and then a smaller percentage will have just Lewy body dementia. And then another condition which is quite rare called cortical basal degeneration. So these are all diseases that can result in the PCA syndrome. And another question many people ask is, why does can a brain scan show PCA? Well, we can't be certain that somebody has PCA or even what type of disease they have for sure with current scans that are available on a clinical basis and not a research basis. But certain scans can point to the diagnosis in the right clinical setting, meaning you have the right symptoms, and then we look at a brain scan and we can say everything fits with PCA. So if we look at our top row of images here, just to orient everybody, probably the best slide to look at, or the best photo to look at here, would be under B, where you can see the nose and the eyes. And it's as if the person is looking straight up to the ceiling, and here's the back part of their brain. Here's an area that sort of runs through the cheeks, so before you get to the eyes. And again, here's the back part of the brain. The area that is affected is not in this area in slice A. This is the balance center of the brain called the cerebellum. But back here in the occipital regions is where we start to see loss of brain tissue. How do we know there's loss of brain tissue? Well, we see increased space between the brain tissue. So brain tissue on this scan in B is represented as gray, and then the space between brain tissue is represented as black. And so we start to see that as the gray tissue starts to shrink, there's more blackness or more fluid taking the space over where the brain has started to shrink. And you can see that even better in C, where you start to see these black regions start to fill the spaces where brain tissue has been lost. And then if you go at the very top of the brain, you see a very similar effect, but not as severe because we're not in the area of the most damage. Down below is something called a PET scan, and this is a positron emission tomography scan that some of you may not have had, or patients may not have had, but we can use this to see what areas of the brain are active. So this is really looking at activity. Just to give an analogy, if your muscle is at rest, there's less blood flow running through the muscle, there's less metabolism. When you start to move your muscles, the metabolism in that muscle increases. Well, the brain is very similar, and we have this type of scan that helps us see the activity that's happening in the brain. So again, here now in E, the back part, the balance center, all of this colorful area that is in yellow or gold is seen as very metabolically active. But now if we move to F, we see how these areas of the brain are not metabolically active, and that's represented by this purplish color or lack of the gold. And we see that in a similar manner in G. So the areas of the brain that are losing function are due to the fact that we're losing cells in that area, and the absolute sort of metabolic activity is decreased. So can a brain scan diagnose PCA? No, but can it show us the features that help combine with the symptoms that somebody's experiencing and the examination lead to the diagnosis of PCA? So another question that's frequently asked is, can it be directly inherited? Meaning, if I have it, can I pass that on to my son or my daughter? Or if my parent has it, can it be passed on to me? And there is no evidence for a direct inheritance pattern. And I'm going to talk about what I mean by direct. We know that if we take, for instance, Alzheimer's disease, about less than 10% is directly inherited, meaning if you have a gene, you can pass that on directly to your child, or you can inherit it directly from a parent. We call those determinant genes because if you have it, then it's determined that you will develop the disease. There are genes that you can inherit that increase your likelihood that you're going to develop Alzheimer's disease. They're not determinant genes, but instead they're risk genes. And many of you may have heard of, for instance, the ApoE4 gene, which is a risk gene. If you carry that particular gene, that doesn't mean that you're going to get the disease. So it's not a determinant gene, but it increases your risk for getting the disease. And right now, as you'll hear from Dr. Rabinovich, his talk that Jamie has on her website, you'll hear a little bit about how researchers have found some areas of our genes that potentially provide risk for PCA. And there's much that needs to be done. When researchers are in the identification phase for determinant genes or risk genes, we need many people to participate, and usually in the range of 1,000 or more at least, to find these risk genes and these determinant genes. And so time and a lot of effort, and many of you have probably participated in providing blood samples for what we already know in terms of areas that may increase our risk for PCA. So we have to thank you for your participation in that. And then lastly, can we treat PCA and will it get worse? First, we know there's no treatments that stop the disease, but we can treat the symptoms. So Alzheimer's disease, Lewy body dementia, and even cortical basal degeneration, there are specific medications that can help treat the symptoms, but not necessarily, and we know this, stop the disease. And many, when we did our Facebook survey, we found that many patients, in fact, the majority, are on medications that are approved for Alzheimer's disease. And then lastly, will it get worse? And the answer is unfortunately yes, but it is very difficult to predict how fast and in what manner someone will worsen. Every patient is very, very different. But because that's a question that, not surprisingly, is on everybody's mind, a group at the University of College of London, led by Sebastian Crutch, which many of you know and have read and learned from. He runs the Rare Dementia Support Group, and he's a neuropsychologist, and he decided, along with colleagues, to really provide some framework for people regarding the stages of PCA. And I put here a link where you can find these that I'm going to review, and you can find the handout about this. The easiest way to do it, if you search stage PCA, the first two hits that you will get in that Google search will be the Rare Dementia Support Group Stages of PCA document. So it won't be hard to find, and then this link will be up on Jamie's webpage. But here are the stages that he and his colleagues, and you can see their names there, have written to help people to understand what things might be like in the future. And stage 1, they considered absolutely no impairment. Stage 2, a very mild decline. And they have written underneath each stage, which is very helpful, some terminology that kind of helps you understand what very mild decline might mean. And that means for stage 2 that something is wrong, but it's not quite clear what. This may include problems that are only recognized in hindsight, meaning once the diagnosis is made and people understand it a little bit better, they may say, well, now that I think back, 3 years ago, there was this incident or this episode, or I had these problems and they were likely PCA. At stage 3, which is typically when patients may actually start to go to see providers, particularly eye care providers, there's mild decline. And everyone, coworkers, family members, starts to accept that really there is something wrong. May not be wrong all the time. There may be days or weeks or even months where things are very easy to do, but there are particular things that that the person will find it very difficult to do, or problems become more difficult to solve. And at stage 4, there's moderate decline, and problems can be debilitating, meaning activities that the person was able to do in the past can no longer be performed. And this may be even with everyday activities. being able to fix meals, get dressed, things like that. In stage 5, it's considered a moderate severe decline stage. Problems are now very debilitating, and help may be required most of the day and at least every day. And then severe decline, significant problems across a range of thinking, not just vision and other sort of sensory abilities. And so we might consider this stage a more global dementia starting to develop or become evident. And then stage 7 is the very severe decline stage where many of the basic abilities become lost. Now, I must add that some people may skip over a stage. Some people may stay in a stage for many years and have other problems and not get to stage 6 or 7, for instance, before other issues take hold. So this is a rough framework to try to help guide people to understand how things could occur and potentially identify which stage you may be in. And I'll be happy to answer some questions at the end about this, because this is probably a sticking point that's very difficult for us as clinicians to provide good answers to, because everybody is so different. So now I want to move on to talk about how PCA affects the visual system. And I think to understand that, we need a little basic anatomy lesson to really also understand what providers, when you see them, are looking at when you tell them about visual symptoms. So the first thing we know is our visual sensory organ, for instance, is the eye, of course. And everything in the world is really represented by different features of light. So the world is sort of broken down into light for our eye to capture. And so the eye actually starts doing some processing very early in the course of getting that visual information. So already, even though we think of the eye as just the sensory organ to take in the information that the brain will then process, there's actually a lot of processing that's already happening in the eye. And things that we hear about in grade school and often sort of stick with us are these terms called the rods and the cones. We remember that the rods are really important for dark environments, and that the cones are really important for being able to recognize details. Well, these rods and cones are taking in all this information, and they're sending it to an area within the eye called the optic nerve. And that optic nerve is taking every bit of information and sending it back to the brain. So the eye is not sending information in any other way or by any other mechanism besides the optic nerve. And the optic nerve is really an extension of the brain, or part of the brain, as is the rest of the eye, or the retina. So the rods and the cones and the optic nerve are part of the retina. Now, as we age, we often have a cataract, which is in this area where I have my pointer on, and this is called the lens. And the lens starts to become opaque or fills with a change that you will need, and oftentimes later in life, to have the lens removed and a new one replaced. And the lens material sits more in the front part of the eye, along with the cornea, which is the most outer area of the eye that covers the eye and helps focus things so that the rods and the cones can really make sense of what it's seeing and then pass that information into the optic nerve. The optic nerve has a relay station that's deep in the brain, and the names of these structures are less important, but we have them listed here to sort of help understand how things move along, and that's called the thalamus. That's deep in the brain, and that thalamus then sends signals to the very back part of the brain, which we have listed here as the visual cortex. And the visual cortex is not something that's typically affected early on in diseases like Alzheimer's disease. It may be affected early on, unlike Alzheimer's, in disorders like Parkinson's disease, and that's why we may see people with PCA who have Parkinson's. But the visual cortex can also start to unscramble the information or process the information that comes from the eye and then pass it along to other areas of the brain. And so that's what we're going to talk about next, is how that visual cortex passes that information on to the rest of the brain. So this looks like a bit of a complicated slide, but I'm going to try to break it down for you so that we kind of think about the last slide that we just saw. Here's an area right out to the left of the slide that shows the light coming into the eye. Here's your forehead, the nose, the mouth. And here in this faint picture is the actual eyeball itself. Here's that optic nerve bringing information into the thalamus, and then the thalamus relaying everything to that visual cortex. We have a lot of names, unfortunately, for the visual cortex. It's often called the striate cortex, and it sits within the occipital lobe. So those are a whole bunch of different names that you sometimes may hear people throwing out, and oftentimes they're really referring to the same area. We also have a system that divides these areas into V regions, or V as in victory regions. And so they can be numbered sequentially, V1, V2, V3, V4, and they really start to represent what we call higher areas of visual processing. So these posterior visual regions initially act a bit like the eye. They have a lot of information, but it hasn't been quite processed yet. And then it sends information throughout the brain up to the top parts of the brain called the parietal lobe, and then to the side parts of the brain called the temporal lobe. Here's that area of the brain that I showed you on the scan called the cerebellum. It sits in the back and even lower and is really important for balance. That's not significantly involved with posterior cortical atrophy or diseases like Alzheimer's disease. So next, let's break this down a little bit about what the occipital cortex or the striate cortex or visual cortex, all those things meaning the same thing. Let's break it down and what those areas do. So if you injure this back part of the area of the brain called the occipital cortex or the primary visual cortex, you will be unable to see light. So that's our first relay station, and it's very similar to the eye. In fact, many years ago, when the discovery was occurring about this area and what it did about 100 years ago, we learned that if you injure that area, it's very similar to injuring the eye, meaning you are blind, you are unable to see light or images. But as we move outward from there, you end up, if you have a problem in that area, you'll end up having problems interpreting the information you see. And if you move upward towards the parietal region of the brain, where it says spatial, you may have problems with spatial relationships, understanding and identifying spatial relationships or where things are in order for you to move in your environment. If you injure a lower part of the brain into the temporal lobe, you may have difficulty understanding what objects are, or potentially how to use the objects because their meaning starts to be lost to you. So you'll be able to see, but not be able to interpret what you're seeing. And oftentimes this is referred to as the two visual pathways, the spatial pathways that move upward, or the where pathway, and then the object pathway that moves inferiorly or towards the temporal lobes, called the what pathway. So let's explore this a little more. And before I do, I just want to mention another pathway that sort of sits at the junction of these two pathways called the motion pathway. That's the pathway that helps you bring together information if it's moving or if you're moving through visual space. So let's say you're just walking down a hallway or you're in a car. You need to process that information even though it's moving across your vision. And there's an area of the brain that's dedicated to doing that. So to go back in history a little bit, back in 1982, Mortimer Mishkin and Leslie Ungerleider at the National Institutes of Health discovered these two pathways, or at least helped build upon the information that was already known about these two pathways to really solidify our understanding. I had the pleasure and the ability to work with them in the late 80s, and they're really an incredible duo that really brought us to an understanding of these visual pathways that really helps inform everything that we do, and probably informs how your physicians are speaking to you about your vision in the back part of the brain. What they did were elegant experiments in understanding that if this inferior temporal region of the brain is injured, you will have difficulty with with object discrimination. And so in their experiments using primates, they did use monkeys, and I am aware of the sensitivity of this type of research that some people are very uncomfortable with, but I would like to describe it to you, is that in monkeys, very carefully removed part of their temporal lobe and found that they had difficulty trying to discriminate between two objects. They trained the monkeys to be able to discriminate them, and then they carefully operated and found that once they had the operation and they recovered and they were healthy, they were no longer able to perform the task of being able to discriminate between two objects. But in other groups of monkeys where they injured or took out carefully a part of the brain in the parietal lobe, they then found that they were unable or had difficulty being able to discriminate spatial relationships. So being able to discriminate how close an object was to one area of the setup to another area. So we learned and solidified our information that that area of the brain is very important for spatial discrimination, and this area is very important for object discrimination. And we can really use this information to inform us about symptoms. So let's talk about some of the symptoms that occur in PCA that may be within that spatial pathway. Well, one that many people describe is missing objects that are in plain sight. And we hear this a lot is when you go to look inside of a refrigerator and you're really looking for maybe the leftover pasta that you want to find. Suddenly you look and it doesn't seem to be evident to you, even though it may be within your plain sight or be right in front of you. That may be a spatial pathway symptom that is very common in PCA if that pathway is affected. Another aspect is you can see details, but you can't see the big picture. One of the ways we can test for this is with an image called the Navon letter. Here you see a patient looking at a Navon letter, and for those of you who can see this, this image is made up of very large capital letter B's, and the image outline becomes the letter M. Well, it may be very easy to see all these detailed B's, but to put it together and understand that this is a big M is very difficult when you have injury or problems within the spatial pathway due to PCA. And many times we'll hear patients describe that, I don't understand how my loved one can see a little tiny object that's sitting on the floor, or maybe a little piece of paper or a piece of trash that's sitting on the floor, but can't put together a bigger picture of how to walk around in a grocery store, for instance. There may be misperception of depth cues or loss of good depth perception, reaching out to grab an object or trying to create actions based on what you're seeing with your hands, or even in a walking pathway may be very difficult because of this spatial pathway symptomatology. So what about the object pathway? What symptoms might we hear that allow us to realize that the object pathway may be what's impaired? Well, this is a little less common in PCA, but it still can occur. But this is poor recognition of faces or colors. It may be more subtle, or we may see it in the later stages or not at all in some patients, where you have really a difficult time putting together the features of the face to really know who it is that you're looking at or to recognize who it is that you're seeing. Oftentimes, if you then hear a person talking, you may then easily recognize who that person is. And then decreased recognition of objects, again, less common to have object pathway involvement, but some people may be very prominent. And this is particularly true under low contrast. So let's say you're looking at something in low lighting, or the image or object that you're looking at is gray and the background is gray. It may be very difficult for you to understand the features. And so contrast, the greater the contrast is, the easier it is to understand. But the lower the contrast between what you're looking at in the background, the more difficult it is. And reading problems, being able to recognize words or interpreting the words as you're reading can be difficult, and we believe that this occurs along that object pathway. Now, of course, there are other symptoms that we'll talk about that come with PCA, but before we do that, I don't want to misguide people to think that these two pathways don't work together. They work together very strongly to help create images and create a good understanding of what's going on. And that may be another problem with PCA, is that if these two pathways are not well connected and working together, it may be very difficult to understand the visual world. This is an example of experiments that we did here in trying to understand how the brain works potentially while walking through an environment. So let's say you're in your bedroom and maybe the lighting is a little bit low and there's an object on the ground. And let's say it's a slipper that's been turned upside down. And that's why we have these pictures of the slipper here for you to look at. And you're somebody with PCA and you're walking towards that upside down slipper, and you're starting to walk and maneuver around the slipper to better understand what it is you're seeing. Well, we created a task that did that for you, so that you sit still and then you watch the object move and then you respond to what you're seeing. So that was a task that we put people through who are very healthy. These are people without any problems with PCA, without any problems with Alzheimer's disease. And we said, well, let's have you just look at this image as it rotates. And so as it rotates in motion in real time, you'll get a sense of what it looks like over time. And as it rotates, or as you move around an image, you'll be able to see it and understand it much faster than you would if you just looked at snapshots. And this is the cutoff point for recognizing an image as it's moving. By cutoff point, I mean if you are watching it move, you'll recognize it well before it's at a 45-degree angle to you. And then we did this task while healthy people were in an MRI scan, and we looked at the metabolism and said, okay, what parts of the brain are very active during this task? And that's what you see down here. You see a side view facing to the right. Here's a side view of the same brain or the same image facing to the left. And you see all these areas of the brain. In fact, you see these three areas that we just talked about all activated at the same time to perform this task. So these two pathways, the one that's important for object identification, one that's important for spatial relationships, and one that's important for motion, they're all working together to help you understand your world. So these pathways don't just work separately and then later make the understanding come together. They're all working together simultaneously. When we did this same task in people not with PCA but with Alzheimer's, we found that they had an extremely difficult time understanding what they were seeing as it was rotating, some not being able to recognize what they were seeing until the image was fully rotated around 90 degrees. And we understand that these pathways may not be able to work together in that condition. When we did try this in some patients with PCA, we found that it was very confusing and very difficult. And so by the time we're making a diagnosis, these types of tasks are already very difficult to perform. So lastly, a couple more things to finish up with here is there are other visual symptoms that don't fit neatly into those pathways, and that's peripheral vision loss, inability to copy designs, and many people have experienced being tested for those things. Difficulty following motion. So while you're trying to pour something into a glass or maybe track something in the sky or in the car, all of those things are visual issues, don't fit perfectly for me to label them in those particular pathways. And then there's other things that Dr. Rabinovich talked about as well in his talk that go along with PCA, and inability to calculate or use objects. Sometimes a decreased fluency with words can start early, decreased ability to write, and even confusion with left versus right. And so many people will ask, well, why, when I went to the ophthalmologist or my optometrist, did I have to keep going back without an understanding of what was happening to me? And well, simply put, is when we see your ophthalmologist or your optometrist, that doctor's role is to really understand what's happening in the eye. So they're looking at the front of the eye, understanding the iris, understanding the structures around the iris, this brown area here, and some people blue, gray, other colors, the colored part of your eye. They're looking at your lens to see if it has a cataract, and then they're looking back in the retina. Do you have a retinal detachment, macular degeneration? So they're really looking at the front system. They're not really exploring the brain when you see an ophthalmologist. So one thing they may do, and this is the way they often present to a neuro-ophthalmologist, is visual field testing. And what we find is that even early visual field testing, this peripheral vision, may be decreased. These are visual field tests that to try to explain what you're seeing here is, if you're looking out at the world and we represent it as the center area where you're focusing is in the center of this cross, we can put little marks where you can't see well. And so if this were the right eye to the right of the screen and the left eye to the left of the screen, you can see that patient 1 is not seeing very well off to the right. And this is 5 years into the symptomatology. We've seen patients even 2 months into the symptomatology where they cannot see well off to the left in this patient 2 example, and that the visual field problem has already started even when a person is only at 2 months. So we do believe that the problem begins in the brain early, before, and Dr. Rabinovich talked about this as well, before a person even starts to experience symptoms. And visual field testing may allow an ophthalmologist and an optometrist to realize that the problem is in the brain. So vision-based treatments, first we always start with treatment of eye problems or eye diseases. Keep your glasses updated, treat dry eye, remove cataracts when appropriate, treat macular degeneration, because if we can get the picture at its best in the brain, then we will have improved ability to process. And early on, low vision consultation or an occupational therapist may be able to help with some skills.
This is what she's saying.
So I'm going to go to one last slide. And I just want to finish up by talking about the important needs of caregivers, because I know we have a lot of caregivers online as well. And that caregivers play such a big role, but they need to also take care of themselves. And I thank any caregivers who are online who participated in our Facebook survey. We had 22 answer our survey. And just to briefly describe part of the results that we have, we can see that there were more female than male, and it may be a result of who decided to fill out the survey. And I can always answer questions about that. But we can see that if we look at how many had described stress above an index point, above 7 points on this caregiver stress index, that shows a very high degree of stress, it was the majority of people. That's here in purple. And if we look at depression, same way, the majority were suffering from symptoms of depression. A large degree of hours dedicated to caring in a day. And even with people with PCA with only moderate to mild impact on what we call ADLs, or activities of daily living, there was still a lot more caregiving than goes on usually with only moderate to mild impairment. And then we can see the degrees or the years that the person that they were caring for had been suffering from symptoms. So even 1 to 6 years correlates with high degrees of caregiver depression, stress, and caring. So we need to make sure that our caregivers are also taking care of themselves in this disorder and getting support that they need. And none of this information would be well understood or known without really teamwork at the University of Colorado. So I want to thank all of those who participated in the Facebook surveys, who are part of our collaborators, who work at the Rocky Mountain Alzheimer's Disease Center, our funders, and then, of course, our patients and families and caregivers, and Jerry Luskett as our administrative director for our Colorado PCA support group. And thank you to Jamie and Michael for allowing this online webinar to occur. So thank you.
That was terrific. Mike, I don't know if Michael's with us, but we're going to take some questions now. Yeah, go ahead, Mike. You're on it.
Well, I was just going to say it's time for some questions. I have muted you, so you can reach out and unmute yourself, or you can certainly use the chat thing. And if you can't figure out how to unmute, just wave your hands frantically and I'll figure it out. There's a question here from Kay Fletcher. What is Jamie's webpage URL?
It's pca-vision.org. Any other questions?
Don't be shy.
Hi, I had a question on navigation. Is that also part of the pathway section? Because we're dealing with complete loss of navigation. Questions like, am I right side up, upside down? Can't find anything. And I was just curious what part of the brain that would be navigation.
Absolutely. So navigation will be in that area of the brain that's important for the ability to understand spatial relationships. So up into the parietal lobe that I described, a very common symptom is inability to work around an area of the house that has changed, or a new grocery store. And then sometimes as things progress, it becomes difficult even in familiar places to navigate. So it can become a significant problem.
Yeah, we have, look, Pam again, we have the problem with absolutely no navigation now. The other thing we're getting is where she's describing things she's seeing that are very strange. For example, the gray bathroom rug, which is no longer there, but she used to call it a gray squirrel. She's calling things, she can almost see the color, but yet she's saying it's the wrong thing.
Right, so that's that misinterpretation of that visual information. So once you get that visual information into the brain, you need to interpret it and understand the shapes that you are seeing to put it together. And instead, it is like unscrambling a puzzle. So you might be looking at all the puzzle pieces and seeing the pieces of the puzzle, but how they make a whole pattern and being able to recognize the pattern they make can be very difficult. And in terms of trying to localize that to just one area of the brain, that may be very difficult to do. And it may instead be really a combination of having all of those areas of the brain work together to understand what's being seen. I hope that helps to potentially understand it if you think of the analogy like a puzzle pieces and seeing the pieces, but not being able to understand what you're seeing and misinterpreting what the object is.
Just to piggyback off that question, how does that, my mom in the beginning of her, what we thought was Alzheimer's, she was originally diagnosed with Alzheimer's, she was seeing people and having hallucinations. I didn't hear you really touch on seeing things that aren't there. Is that part of PCA?
Yeah, so that's a very good question. So we know a bit more about Alzheimer's than PCA in general, about the percentage of people that experience hallucinations. And it's generally about a quarter of people with Alzheimer's will experience hallucinations. And we think that depending on the problem that PCA is caused by, you may experience hallucinations more than the average person. So for instance, with Lewy body dementia, the experience of hallucinations is much greater than with Alzheimer's. And so sometimes we use the clues of, frequent hallucinations or common hallucinations to guide us to believing that maybe there is a different underlying cause or a combination of causes. So yes, visual hallucinations can be a part of PCA, and there are some medications that may help dampen them, but only if necessary, so that you don't cause more side effects than harm.
This is Kay. When my husband and I are walking, he tends to walk very, very slow, and I assume it's just because he can't process the motion, and that's fine. But then in other circumstances, like at the grocery store, or recently we were in an airport, and I would just say, stay with me while I look to see what bus we're supposed to get on. And seconds later, I see him walking 15 feet away from me, and I don't understand the piece of he just takes off.
Yes. So that is not uncommon to hear, and we've heard that many times from our patients. And again, it likely is those areas of the brain working together, not just one simple area. And motion is extremely difficult to process. So anytime you're moving throughout your environment, you're having new signals coming in at you very, very frequently. And what we have seen and heard is that some people will focus in on one thing. And so your loved one may be focusing on one area of you. And if something shifts his attention or her attention, and suddenly they grab onto what they think is the back of your head or your blouse or your purse or anything, any feature that you are, that they had seen that you have, they continue to follow that feature thinking that they're going in the right direction and that they're still following you. And one of the ways that if that problem does exist, one of the things that we've recommended, which everybody's different, it may or may not work, is that you find something that wouldn't be common in the environment you're going in. Maybe it's a fluorescent shirt, a fluorescent tag, something that they can grab on that they're not going to also see within that environment. We've also heard that airports can be extremely difficult for people. I think there's a high level of stress that happens when anybody's traveling. And you add that on top of a new environment and one that's very fast-paced with a lot of motion, a lot of visual signals going on. It can be very difficult at an airport.
Okay, thank you.
Sure.
I have another question. We recently found out or she was recently diagnosed with PCA. She was diagnosed with Alzheimer's probably 6 or 7 years ago. But this new neurologist that we're seeing said it's actually PCA. And after doing a lot of research and being a part of this Facebook group, I realized that it definitely is PCA for my mom. Is it safe to say that she does not have Alzheimer's and it's PCA? Like they're not one and the same? I feel like there's a very blurry line there.
Yes, and I think this is one of our most common issues that people have trying to grasp. And one way to think about PCA is PCA may best be described as a syndrome of symptoms caused by a disease. And the most common disease that PCA is caused by is Alzheimer's. So if you say that somebody has PCA, the likelihood that it's due to Alzheimer's disease is very high. It may be as high as 70 to 80%. And it's not a guarantee, but it is, as I mentioned, a very high probability that that's the cause of it. Does that make sense? Because I know this is a difficult topic.
It sort of does. She was also, this neurologist who diagnosed her with PCA says that she also has like atypical Parkinson's, I think is what she called it.
Okay.
And so, again, it's just very blurry for me. The easiest thing to do when people ask is to say she has Alzheimer's because people understand that. But for my own knowledge, I would love to know if it's caused by Parkinson's or if it's caused by Alzheimer's, or, I don't know if there's a way to know that for sure. I don't think there is.
Well, let's talk about that a little bit. So and only information we have is from people who donate their brain or they have an autopsy done. And what we've learned is about 70 to 80% of people will have Alzheimer's in their brain as their cause for their PCA. Another group will have Alzheimer's with some of the same proteins that are abnormal in Parkinson's. And so that's called Lewy body dementia. And then there's another small group, and maybe it's just a few percentage, 5% or so, that just has the Lewy bodies, which is what we see in people with Parkinson's disease. And so you can have Alzheimer's with Lewy bodies, or just Lewy bodies. And how would we know that besides autopsy? Well, very recently, there's a study that's sponsored by Medicare that Dr. Rabinovich, and he mentioned it in his previous talk that's on Jamie's webpage, that he's the director of, to determine whether or not it's useful to do a brain scan to look for the proteins that are due to Alzheimer's disease. And these results and our ability to use this outside of research will likely be determined in the next couple of years. But if you did this special kind of scan, the tracer that's given during the scan will bind to the protein in the brain that causes Alzheimer's. So then you will be able to see whether there's an accumulation of the Alzheimer's protein to allow you to say that the posterior cortical atrophy is most likely due to Alzheimer's. Currently, that's called the IDEAS study, and it is a research study. And those scans can be paid for out of pocket on a non-research basis, but they are very expensive, and it really depends on the physician that you're working with and the location that you are, of whether or not you could get one of those types of scans. I hope that helped clarify these blurred lines.
Yeah, I just want to jump in. There was a request on the chat for you to put up the second to last slide with a chart showing caregiver depression.
Sure.
Okay. A couple other questions from chat. I'll ask a couple of them, then you can figure out how to answer them. One was a quick question: will a person go totally blind? That's question one. Question two is, if you have two family members with PCA, how long will it be before a test is available, read genetics to kind of unwrap that? But okay, I'll let you start with those two, and then there's a third one from Isa.
Okay, so the first one is, can you go completely blind? If the disorder progresses for many years, we have seen people unable to interpret information beyond hand waving. So you're able to tell that there's some movement, or you can see the outline of a hand. So it's possible to have that degree of vision loss. But there's very few people with PCA that have that degree of vision loss, even well into 10, 12 years of the disease. And in terms of the Michael, could you repeat that last question?
The second one is about genetic testing, and when will it be possible? How long before we can test if you have two family members with PCA and correlating that?
Sure. So right now, a genetic test cannot tell us whether or not you have Alzheimer's disease. But again, if we go back, maybe instead of this second slide, I could jump up to the initial slide when I talked about genes, so that we just kind of get all on the same page here, is that when somebody has genetic Alzheimer's disease, that's really less than 10% of people with Alzheimer's. So by far, Alzheimer's is more of what we call sporadic. It's not directly inherited from a parent. So less than 10% of the cases are determinate gene issues. And those patients begin their disease often very, very early. And even now, when we have these genetic tests available, they're not what we rely on to make the diagnosis of Alzheimer's disease, even in those cases that we think it's an inherited cause. But there are risk genes that we may one day be using because we want people to be diagnosed much earlier before they develop a lot of symptoms or even any symptoms. And so when we look into the future, we may have risk genes, but we're not going to, at least in the near future, use genetic tests to make the diagnosis. So now circling back around to really directly try to answer that question is, currently we're finding some genes that may increase your risk for PCA, but we do not have any genetic tests that allow us to make that diagnosis. I hope that answers the question, and now I'll go back to the last slide that shows the caregiver survey.
All right, and one more question from the chat. Would you consider using analogies to explain PCA with people who suffered a stroke in the same region of the brain? And how would you explain to others so people don't jump to the short-term memory loss conclusion? What kind of memory loss is involved? Right. So
that's a very good question. So when strokes occur in the back part of the brain, oftentimes there's one problem that's lost. It's not as difficult sometimes to manage if it's only in one region of the brain instead of the connections between the brain regions or multiple areas lost at once. So when somebody suffers a stroke from this area, the problem stops, meaning you've had the stroke, now the compensation can begin. With PCA, it's very different because there are disconnections between the areas of the brain that don't occur in stroke or occur to the extent, and the problems continue, and there seems to be multiple visual regions, not just one involved. So it can be a very different situation. And in terms of really trying to guide therapy or help people understand that it's not just a memory issue, it really involves educating both the people who provide care, like what Jamie is really trying to do with her science articles and getting them on the front page of Neurology Today was very important. Having speakers such as Dr. Rabinovich, Dr. Crutch, myself, and multiple other researchers talk about the visual areas of the brain as being an area that is similar to memory. It needs to process information. It doesn't just happen all at once. And so really educating people is probably the most important, and simply telling people that the problem is not due to memory, that it's really due to how they process information. Many patients and caregivers discuss this problem as the person with PCA looks just fine, like there is no problem, when in fact there's a major problem with processing visual information. One of our, several of our people from our support group often carry the canes that people use or recognize for blindness, which is a white cane with a red tip, not because they need that for everyday activities, but because it's very useful for others to identify that they have a visual impairment.
Okay. Michelle or Mikale, did you have a question?
It's Michelle.
Michelle.
Yeah, I do. Dr. Pelak, do you think that, I have conversations with Chris all the time because he'll do these strange things as far as, he still does a small daily task of cleaning dishes. But, he'll put things on the kitchen hearth because he can't make them fit in the cabinets or the stacking, and he doesn't have abilities. Do you think he's even aware that he's doing this? That's where I have a hard time when I'm having a conversation with him and asking him, he knows that his brain is not working or is messed up or whatever, but I don't know that he really is aware that there even is certain issues like that. One time he was meeting some people and he went to shake their hand, and of course, his perception of where their hand is was off, but he didn't even flinch, like it was no big deal. We just, moved his hand over to meet the other person's hand. and it was fine, but there's no acknowledgement on his part. And I don't know if that's unique to him, just how he handles things, or if that's kind of a common, they just aren't aware that they're off like that, or there's an issue.
Right. I think as things progress or change, oftentimes it is very difficult to know what they just misperceived. And insight can vary greatly, meaning the ability to recognize when your perception is not meeting reality can vary between patient. And oftentimes, some people will be more affected by not realizing what mistake they've made or what misperception they've had, versus another person who will be very aware that they just made a mistake or that they can't get to the hand. Okay. And so it's, number one, it's very variable. And number two, simply asking may help afterwards, did you realize that you couldn't find the hand? And they may have very good insight, but didn't want to call attention to it, for instance.
And that's what I feel that I'm kind of becoming more self-conscious about, because I don't know that I'm scared to make him aware or even approach that, because I don't want him to feel, I don't know if the word is bad is appropriate, but, he's always been very disciplined as far as working out and things like that. He goes and works out on, and if he misses those, he's very much upset. You can just tell his demeanor is different, but he doesn't acknowledge that that's important. He doesn't acknowledge that he's can't do things. We just kind of don't talk about it, and I don't correct him.
I think I'm losing some of the.
Yes, we're losing a little sound there, Michelle.
Okay. I can.
Oh, there you are, Michelle. Sorry, we lost the end of that sentence. There was a technical.
Oh, I don't know that I'm. I feel that I'm taking it on a little bit too much. I'm starting to feel more and more stress, but I don't want to make him feel bad or make him acknowledge something that he does or doesn't know about.
Exactly, and I think that. This we can speak to as finding that proper balance, because it's going to be very different for everybody. Some people will really want to know what's happening, what was that like? How did I appear? Whereas others would prefer not to call attention to it unless there's a problem. The person is maybe being put in harm's way or causing more problems by, misdirecting a pitcher full of milk into a glass, things like that. So it's really trying to talk through it if the person wants to, so that you as a caregiver can find that proper balance, because there's definitely not going to be one answer for everybody.
Okay. And I have small kids now too, so I'm kind of, I feel kind of sandwiched, because I want them to be aware of it, but they're 14 and 12, so I want them to have a normal life, but then they're feeling a strain of like, well, when their friends come over, even though know about it, because we have a tight network of friends, they're starting to feel like the normal, they don't want to kind of deal with it, or it's not, but I just feel really sandwiched in on being able to know what's appropriate. I talk to them and I'm going to watch this, obviously, and the other one, just to have a better understanding for themselves. But it's really strange, because I don't get any support from Chris telling them what's going on, but it's hard.
Okay.
Hey guys,
I was going to say that.
Yes, Jamie.
Well, I was just going to throw it to Jamie, because that's why she wants to have these online support groups.
We're going to have to wrap up now, but we will continue this conversation at another time. We're going to be creating a support group. Victoria, Pelak, thank you so much.
You're welcome. Thank you.
And if there's any other questions people have, just email me and I'll get them to Dr. Pelak. Thank you all so much, and I'll see you next month with Brad Dickerson from Harvard. Have a great day.
Thank
you all.
you.
Thank you very much.
Thank you.
Thank you.
Thank you, Jimmy.
Thank you.